Hi, Marcelo.
Hey,
How are
Mark.
you?
I'm fine. How are you? In fact,
Good.
good, great. Look, first of all, thank you so much for spending an hour with us. In my name and Tamussino, who represents Cook in Brazil, you know. So
Yeah.
thanks a lot to with us tonight. So how
Happy to
things
be
in
here.
North Carolina?
Things are good. We have a little rain here today, but it's not so bad. It's typical now because it's starting to get to the end of spring and summertime for us here.
Good, good, good. And so I think North Carolina, especially Chapel Hill, where you are based, are did not get a hit from the COVID infection.
No, Marcel, you have visited here. We are not a large population. The whole area where I am is maybe 1 million people total. So every day the hospital sends us an update. We only have about 20 patients in the hospital with COVID. Maybe 15 of those are in the ICU. And we have about 4 or 5 of those patients on ECMO of those 20. But they say that this will continue at this pace until mid-September. So they don't see that the numbers will start to decrease until September where we are. So it's not a lot, but it's very constant and will be very long.
Interesting, because here in Brazil, in spite of the news, what we see in the hospital where you work here in Rio, that a decreasing in the intensive care occupation. So it looks like the curve, as they say, is going a little bit down. Hi, Álvaro. Hazuki from São Paulo is also with us. Neide, our national secretary. So thank you for coming. Thank you for being with us. So it looks like it's going down. And you said an interesting thing. You have a hi, Tom. Tom from Poland is with us tonight. Hi, Tom. And Mark, well, you don't have a lot of patients, but we have a lot of patients on ECMO. Here, we have very few patients on ECMO. It's quite interesting.
Yeah, so we have a busy ECMO center, and so there is a very little data, as you know, that ECMO does a lot of benefit. The problem for vascular surgery is that I don't put the patient on ECMO, but when they have a complication, I need to come and take care of the complication. So while I'm not directly taking care of patients with COVID, I'm indirectly taking care of patients with COVID because we get leg ischemia because they don't put the perfusion cannula in and so forth. And then we have to go repair the artery because they do it percutaneous and they don't put any closure devices in. They don't know how to do that. So it adds complications for us from that perspective. But probably what impacts us with COVID more than anything else, Marcelo, is the fact that patients don't want to come to the hospital because they think that the whole hospital has COVID patients and that we're all going to get infected if they come. So my clinic numbers that I see in clinic are reduced. I do a lot of video visits, telephone visits, but the patients don't want to come and get their CT scan. And also, we've had several patients cancel because the hospital won't let you come with your family during surgery. Only you can come. Aortic aneurysm fixed if they can't have a family member nearby, and therefore they delay their aneurysm surgery. And I think we are going to see complications, leg ischemia, ruptured aneurysms, strokes from carotid disease come to all of our practices and become a much more symptomatic practice unless we can get patients back to do their routine vascular health checks.
Yeah, I think there is a lot of things in that you mentioned. First, I think unfortunately, the press, they do not know how to inform correctly people. So people are very scared. And they don't know that only 15% of the patients needs a hospital, and between those, only 5 or less need to go to a breath machine. So, so people get scared. I understand. So we saw that in New York when they saw that 100% myocardial infarcts after COVID infection, because people are afraid to go to the hospital.
Yeah.
And so that do not help. I think they should balance the information and based on the physician information, not in the, getting the first to say, I saw one man die in the street. So they put that, so everyone they don't go to the streets because you're gonna die. It's not like that. But, it's difficult to control. And in case you have a patient with enlarged aneurysms, he's painful, so he asks you, doctor, I'm feeling bad in my belly, what I can do? So you have to do a surgery. Do you have in the hospital any protocol? So they have a CPR or blood tests before going inside the hospital?
Yeah, so now we have a very detailed protocol about whether you're coming from another hospital or whether you're coming as an outpatient to get surgery, about what the protocol is. So if you come to see me because you've got a 8-centimeter aneurysm and you need your fenestrated repair in next week, your device is ready. 3 days before, you have to get a COVID-19 test, and then you have to come to the center and get tested. And then based on that test, it will determine whether you can go. If you are an inpatient and you have to come for an emergent procedure down to the operating room, you have to get tested, and then if you have any symptoms, all of us will be on N95 respirators, and we restrict the number of people in the room because it's the number of people in and out of the room and the contact that makes a big difference. So we have a whole protocol laid out for all of that.
Good. So what do you say about your training? Because I know you have a strong training group of vascular surgery. So what's going on with the beginning of the residence program? The guys that just start, they don't know very well things. So you keep them away, or you may a scale, or how you deal?
So
your training.
Right. So for the trainees in April, we reduced the number of trainees because our volume was down. We weren't doing as much elective. So we rotated the team. We made 3 teams, 1 team at home, 1 team for the day, 1 team for night. And we made sure they were segregated so they did not see each other. And we did that for about 6 weeks now, because if someone got sick, we didn't want all of the vascular team to get sick. But now that things are ramping back up because we have no more restrictions, really, everyone is back to full capacity working. But we did the same with vascular training. We did the same with general surgery training and cardiac. All the trainees did that process. But now the only people are restricted are med students. They're not coming back now for another month.
Yeah, you speak a little bit about, you spoke about ECMO complications, but we saw some COVID complications like thrombosis of the whole femoral, not all the common femoral, the superficial, profunda, the whole artery, the whole tree, below knee vessels occluded. It was very, very interesting to see that acute thrombosis. And then I spoke with Melisano from Milan, and also with Stefan Roulon from Paris, and they saw some aortic occlusions. Have you seen some kind of coagulation problems or thrombus in the aorta, things like that, more complex?
Yeah, so Marcelo, we have a very good hematology department here. The hematology guys are the ones that identified von Willebrand fracture. And so they are internationally known, our guys. So we've had a very big conversation with them about thrombotic complications with COVID. And what is probably, yes, we're all going to see someone that has a thrombosis of an unusual factor. That's rare, but it happens. The issues that we see affect our laboratory, because a patient with COVID comes in and they want to get an upper extremity duplex and a lower extremity duplex and do all 4 vessels and take the technologist to go do that for every COVID patient. We don't have the technologist to go do that. And if the technologist gets sick because they get COVID infection because they're seeing every COVID patient that comes in, then we won't be able to do any emergency, or the lab will have to shut down. And so we had a big discussion about prophylactic anticoagulation in the COVID patients. And so what they do is they look at the patient and they give a score, and it's something that they do with the hemonc department and decide what the risk of bleeding are versus the risk of thrombosis. And if they think the risk of thrombosis is significantly greater than the risk of bleeding, they will anticoagulate the patient, and we won't do an ultrasound test. But we know it's a problem that we have to address from a manpower issue, because we can't test everyone for a DVT.
It's true. It's true. Mark, I'm gonna give you an advice for people with us here in Português. Just a minute. Pessoal, vocês podem fazer perguntas em português, que nós traduzimos para o Mark, qualquer dúvida que vocês tiverem. Ele está falando da Carolina do Norte, na cidade de Chapel Hill, onde voltaram a trabalhar 100% normal. Nós temos aqui um número enorme de pacientes, e lá eles tiveram 80 casos. Então, é completamente outra realidade. Mas podem fazer perguntas aqui. So, Mark, I just saw Júlio Peclá, our future president of the Brazilian Society, join us. Thank you for joining us, Júlio. I hope Mark come next year to visit us.
I will.
So, yeah, I think so. So, Mark, you are now, so said that you become full program working, everyone in cardiac, thorax surgery, etc. And is there any restrictions to travel between states, from North Carolina to go to New York, to go to Miami, Florida? Is there
So
any
right now, yeah, Marcelo, right now we have a list of about 8 states that I can't travel to. If I travel to one of those states in about 15 cities, I have a mandatory 2-week isolation. And not only isolation, but see, I'm at the university, but isolation, I either have to take vacation or no pay for those 2 weeks. So they're going to make it significant, even if I go for personal reasons. And now this is in effect at least until December, they tell us. So it's going to have an impact for the VEITH meeting. I mean, how are we going to do the VEITH meeting, right? This is going to be a big problem, because while the summertime here may help cut the rate down, who knows?
You know,
by the wintertime again, it may be back a little bit. We don't know.
Yeah. November in New York is very cold, very cold.
Yes.
And by the way, I let you know that on June the 10th, Dr. Vieth will be here with us on Instagram Live.
Okay,
so
good. Tune in.
Take part of that conversation will be very interesting, because it's the first time Dr. Frank Vieth goes live in his life. He's very used to go to the conference, but not to this kind of communication. That's be interesting to see him. So I have a question here from our future president, Dr. Júlio Peclá. He said he has 80 cases of critical limb ischemia after COVID-19. And his impression is that the gangrene is more superficial. Uh, stents plaques, 2 cases with podal pulses. So what he said is that the more fingers, we are losing fingers, distal thrombosis that we cannot restore the circulation. Have you seen those things?
No, we have not seen that yet, Marcelo, but you know, that goes along with what they see in the lung, right? It's not the major vessels, it's the peripheral microvascular thrombosis that is the issue. Like I said, the question is, should we, and no one has enough data yet, should we be anticoagulate them, maybe low dose Lovenox? I don't know, you know, to some, but we know that one thing, people are getting severely dehydrated with COVID-19. And that goes along with some microvascular thrombosis, and that's another issue, right?
And they also have high doses of noradrenaline, because when you see that it's distal thrombosis, they have high doses of noradrenaline that does not help.
Yes, I agree.
Good. So let's talk about other things. And I know at this time it will be more difficult to do so CMD devices, probably. I don't know how is the regulations on the FDA and even the CDC in America, but because of that, are you doing more those off-the-shelf cases for a thoracoabdominal, let's say, T-branch or any other one, because or you are doing the CMD the same way?
So Marcelo, I think there's 2 parts. One is, don't forget, with CMD, we've already ordered devices 8 weeks ago, right? So the cases I'm doing now are from 8 weeks ago, which is just when COVID kind of started. So, you know, that impact I haven't seen yet. So for the aneurysms, we never stopped. We always said, look, we're not so inundated. It's not New York City where we couldn't do anything other than emergency. So here we did our urgent aneurysm cases. We did the big aneurysms. So that never stopped. The question will be in the next 2 months whether the CMD percentage changes. Probably a little bit, but not too much, because if the patients come in symptomatic now, then I got to go with an off-the-shelf device, a T-branch, and have to use it. And we have a few that we've had to do the last couple of weeks like that. Although I will tell you, yesterday afternoon, Ezekiel Prodi did a ruptured juxtarenal open, and last night, early this morning, I went and did an open ruptured juxtarenal also. So he did 2 ruptured juxtarenals yesterday, which is rare to do 2 within 12 hours of one another, but we did both one and we did them open. Yeah, both open.
Because you don't have a device for those cases.
One was an 87-year-old lady, skinny, bad access, and the other patient was a bad access. And so I just did an aortic tube graft and, you know, clamped up through bad iliacs. So they're both in the ICU, but doing okay. So we expect one more because, you know, things always happen in 3s here in the States. So probably one will come tonight, maybe.
You know, I just 3 days ago, I had a lady, 95 years old, with enlarging aneurysm. It was not rupture, but enlarging, painful. So we did infrarenal percutaneously. She stayed only 2 days in the hospital. That was, I saw her today in consultation, and she's doing fine. So that was what you said. We see those patients in an emergency. I was very fortunate because my patient has a large neck, long neck, so I could put an infrarenal device without problem, and so I did percutaneous, good access, in spite of having 95 years old.
Yeah. So I will tell you also that Ezekiel and I have started to do some laser fenestrations. So we have an emergency. We don't have a device that fits. They're not good for T-branch. And so we will do maybe a laser fin for the SMA and the renal and the celiac. And we've done now about 3 cases. They go pretty well if you select them. So we don't do everyone that way, but if it's something that we think we can do and do it quickly, then we would do a laser fenestration. And we don't have to wait for a CMD if it's someone with symptomatic or rupture. So that is really, I think, another thing that's in our armamentarium that we can do.
It can help. Can help. Yeah. As long as you have the technology, and as long as you know how to manage that technology.
Yeah.
Yeah, that's the limitation, I think.
Mm-hmm.
Yeah. Good. So, Mark, we just have here. I saw. Did you saw the Compass study or Voyager study from Bayer that they did a study about myocardial disease, and then for disease they make end platelets with 2.5 milligrams of rivaroxaban Xarelto, and they get a very good results with 23,000 patients, less amputation, less infarctus, etc. You saw that?
Yeah. Yeah.
They put it in the New England.
Mm-hmm.
Yeah. So then I discussed with Melisana and Gustavo that we have our Achilles heel of our thoracoabdominals, or even our fenestrator, or even branches, are always the renals, because we don't see many celiac and SMA occlusions. We see renals, let's say from 4 to 10%. Agree?
Yeah. There's always a low number, but it's always present in whatever study you look at.
Yeah. Yeah. So we are thinking making a study comparing keep those patients on platelets as we usually do, and then arm blinded doing platelets with Xarelto, 2.5 milligrams. That can change. And then we are discussing with to make a large group. What do you think about that? Just like that.
Anecdotally, Marcelo, I've had now about 2 patients. I always put patients dual antiplatelet for 3 months. Every patient, unless they have a low platelet count, are on DOAP for 3 months after the procedure. I've had 2 patients now that after they come off Plavix, and I go down to 1, generally an aspirin, they've had thrombosis of a target vessel or a complication related. So there is something to that. We know that there's something to that, and we need to think about it. The other thing I think, Marcelo, that you and I haven't discussed yet is there's a recent article that took patients that underwent coronary artery bypass grafting, okay? And after coronary artery bypass grafting, okay, they took these, patients with carotid endarterectomy. And after the carotid endarterectomy, they were asymptomatic from a coronary standpoint. They got a study to determine if they had a positive lesion by FFR, fractional reserve in the heart. And if they did, they got a cabbage. Asymptomatic, no symptoms. Those patients did better and had a better long-term outcome than those that didn't get a cabbage. So the one thing that you and I and all of us that are doing with endo is that we don't do much of a cardiac workup. If my patient doesn't have angina and doesn't have any symptoms and has an okay echo, I do the thoracoabdominal repair. But we don't do an open repair. We would do a whole cardiac workup, a catheterization, and a cabbage before we do an open thoraco. So I think the other part of your equation is we also need to look at the hearts. And after we finish their endovascular thoracoabdominal repair, if we do a cabbage in those patients that have a positive FFR, we're going to improve our 1 and 3 and 5 year outcomes, because all of us have a 1% 1 month mortality, 8 or 10% 1 year mortality in patients. But if you look at 5 years, it's 30 or 40%. We've got to do something about the long-term mortality, because they're not dying of aneurysms. They're dying of other problems. And we have to address the long-term mortality to improve our results. we can take a 1% 1 month and get it to that 0.5%, but it won't affect the long term very much.
So that could be also one of the endpoints of the study. You
Yes.
can see the mortality. We start with 1-2 years, and then we also, as a secondary endpoint, we see the patency of the renal arteries. So the mortality, general mortality, if you improve it, keeping those with some small dose of anticoagulation therapy. Could
So,
be
you know, in the aortic consortium here, we're doing about 50 cases a month. So we're doing about 500 cases a year in the consortium, the 8 of us. So we as a group have already said the 8 of us are going to do stuff together. So
this
that would be a big.
Gustavo mentioned that. How many centers there are in the consortium?
8 or 9 right now. That's all that have
8.
access to it. So 8, yeah.
So
but, you know, that's a big number for 8 people.
We have a question from one of our friends, a vascular surgeon, very good endovascular, Lucas Freire. He just said recently a paper showed good results with P branch device. Do you think you will have this device available anytime soon? The P
So
branch.
the P branch trial in the U.S. is essentially done. Because it was a prolonged trial, they will go to the FDA soon, I think, and we'll know maybe in 6 months have it in the U.S. But it's available. U.S. It's available in Europe. I don't know what the status of it is in Rio, Marcelo. Do you? What?
Well, if the device is approved in Europe, it has a CE mark, the product could be approved in Brazil. That's usually how it works. I'm going to try to understand. I think Logan from Cook is with us in that live. If he could mention something that does not put him in jail. We are not asking for say secrets, but if he could just mention if the P branch has a CE mark that then could be approved in Brazil, it'd be nice to see that. We have
it's CE mark because Tim Resch has access to it, so that has to be CE mark.
Probably.
Yeah.
Logan asked us which product, P branch. So the off-the-shelf fenestration for the renals, Logan. He will confirm for us. Okay, good. Thank you, Logan. Very, very nice. We have a question here from a cardiovascular surgeon, a very close friend of mine and one of the best surgeons in Brazil, Dr. Leonardo Farber. It's just, you are Farber, he's Farber.
Yeah, I met him down at your meeting. I know Dr. Farber.
Yeah. The rich family stay in North Carolina, Farber. The poor fellow is Farber. Okay. He came back to COVID infections. He asked for those COVID patients already recovered, how many days do you have to wait to operate them? When they will be okay to submit to a huge surgery? So
once there's symptoms
of COVID infection went well, stay in the hospital for 3 weeks, 4 weeks, then go home. When he come back?
So the hospital has, the hospital says they have to have no symptoms for 72 hours. So it's a minimum of 72 hours. But, you know, these patients, they may not have a cough, they may not have a cold, but they may have some lung disease. So we have to wait till pulmonary-wise they can tolerate the procedure.
Oh, that's very interesting, because no one has mentioned that. As I spoke with Gustavo, Melisano, and Stefan, but that is a good point, because most of the sequelas are in the lungs.
Yeah.
So we see that CT scan, very ugly aspect. Would be nice to have before a huge surgery to have the lung function tests, like a spirometry, etc., to see how the guy is doing. What do you think?
Yeah, so Marcelo, the problem is that they have to be asymptomatic, so 72 hours. But really, what you want to know is that what is their oxygen level, what's their CO2 level, how to manage them. So maybe just getting an ABG, you don't have to do a full lung study. Maybe just getting a blood gas will give you enough information to know how they're doing, and that standpoint.
It is, although, look, if the patient has a good recovery, okay. But if the patient, after a thoracoabdominal, has any complication and he needs his reserves, he will not, maybe he does not have.
Correct.
That's my problem.
Uh-huh. So how long are you going to wait?
Logan does that the P branch do not have CE market. We can discuss offline after. Probably Tim Rash is doing kind of study and selected center. Okay. It's not in Europe, neither in Brazil, neither in US. But I hope it will be approved. That would be very nice to have another off-the-shelf device.
Yeah, but even if we get approved in the U.S., you can't use it in Brazil, right? You got to have CE mark, not U.S. FDA. You have to have CE mark for Brazil, right?
No, I think we can have both. We accept the FDA and CE mark.
Okay,
yeah,
good.
You know, I'm doing. I'm not sure we're going to publish that, but we are doing the T branch for those just the renal cases and emergency. Do is I modify the table. I take a window, let's say half of the circle of the background, keeping the lines to maintain the stents together. But I take all the posterior out until the first stent. So in that way, I could do a film. I said I have a film showing the intercostal artery. So I call that the P branch with back window T branch.
Yeah. So
you can use that.
Right. But don't you think, Marcelo, that we're going to have to come up with a decision? Do you sacrifice intercostals? Do you take a risk on the renals? Okay. Or do you just wait for a CMD device? They're all a little different. They're not all the same. Right. And you have to decide what's best for your patient and that thing. And because, even though T branch works in cases, if the order is really small, you may have a kink in a branch. And if you have a kink in a branch, you may risk a renal versus a CMD, so that's what we're all deciding. How long can we wait? How long not? And then what about interbranch? Because I think if interbranch, they can get to here soon, that may also help us. And you're going to have 3 or 4 decisions to think about for your patient.
Well, I think the inner branch, two inner branches for the renals, and one fenestration for the SMA, and another inner branch for the celiac branch. So with that, we have 3 inner branches, 1 fenestration. This device can be off the shelf because you just have to be centralized in the SMA. The other inner branches, they can just, go and navigate inside the aorta. So that could be a good device off the shelf. 3 inner branches and 1 fenestration for the SMA. So you go there, you look for the SMA, and then it's finished.
Right. But, Marcelo, if you wanted to expedite things, the celiac's probably not critical, right? Eric has sacrificed the celiacs that are patent. As long as you have a GDA and you got a good SMA, you'll be okay. So if you had to an emergency, you could just go with a SMA fenestration and 2 inner branches for the renals, and you would be okay. Most of the cases.
Yeah, you're right. You're right. It'll be easier and faster. It's okay. Although we have seen complications of celiac trunk occlusion.
Sure.
Not a lot. Not a lot.
In an emergency, you take a chance, right? So
yeah. So we have another question from Leonard Farber. Yeah, if you have, you need an informed consensus of the patients about informed consent about the patient comes asymptomatic to do elective surgery, but the hospital may have a COVID infection, so he can have that after the surgery. You should inform him. He should sign that to avoid any law complication.
So, I don't think you have to sign that because our COVID patients are in a separate part of the hospital. He's at risk of getting an infection, period. He is at risk even after surgery when he goes home to get COVID, because it's not about getting COVID in the hospital. It's about when you're recovering from surgery, because you're not back to 100%. You're more susceptible. You're potentially immunocompromised for a little while. That's what I informed them about, not about getting it from someone else while they're in the hospital.
Yeah, true. That's true. You never know. Yeah, the patient can say, "Well, I was doing well, and then after my surgery, I got infection." Nobody, you never know. But
no,
it's true. It's a clean situation, and you have two hospitals, so
right.
it's totally different. Good.
Mm-hmm.
So, as we mentioned, we in those emergency cases, it's difficult to make decisions when they go upper above the celiacs, because sometimes you have to sacrifice all the intercostal that are critical, those from T8 to T12. So that's an interesting point, because if you keep the hypogastric open, do you think those, because we don't see in any publication high grade of paraplegia?
So, Marcel, I would tell you now, we've got 300 patients in my IDE, and the consortium has now about 1,500 patients.
1,500.
1,500 we have data on now that we're getting ready to publish. Our paraplegia rate is basically 2%. Our paraparesis rate is 2%. Now, you have to be careful with that number, because there's a high percentage of type 4 thoracos. But when you go to the type 2s and type 3s, it goes up to 3% to 3.5%. That's still low. And in my practice, the only time I've ever seen paraplegia is post-operative hypotension. They've never woken up from the OR with paraplegia. Now, I always do a staged procedure. Okay, so that helps. And if I've got a hypogastric or subclavian, I need to make sure it's revascularized. But I think that one patient had a GI bleed, one patient got pneumonia and got hypotension. And so those are the ones that we see happening. And I think the only ones that I think happen in the ORs, not that it can't happen, is that it's embolic complication.
Yeah.
So I think that happens.
So that is two questions now. So I still believe, I also believe that most of the cases are embolic situations, those shaggy aortas that you manipulate to find the vessel. That's true. I always stage the cases like you, but in an emergency, like a rupture, proximal to celiac, you cannot stage. But even those, if they are not in shock, if they recover well, they do not get paraplegia. It's not common. As you said, it's 2-3%, which is very acceptable. It's much less than open surgery.
Correct.
So that brings us to one thing. What do you think about the Misace study? Those that you bring the hospital 2-3 times before the surgery to embolize the one pair or two pairs of intercostal arteries. I know Melisano is collecting data now. Maybe they stopped because of the COVID infection, but they will do. I'm very afraid of doing that procedure, because only looking for the intercostals you can embolize, as you mentioned. You can embolize from the SMA, but you can embolize looking for those arteries. Are you being part of this study, or what do you think about?
So no, we're not part of the study, Marcelo. You know, many years ago, they did that. They used to go after and try to find, remember, the art of adding K-wits and identify which one you need to put in. And maybe the techniques 20 years ago to do intercostal angiograms were not as refined as now, but they had complications of embolization during those procedures. So if you look at the trial data, though, remember, it excludes patients with hypogastric disease. It excludes patients with subclavian disease. It excludes patients at a risk of embolization. So you have all these patients that can't even get it done. So it's not a true comparison to what you and I do with staging for open, okay? And so I have a problem with that because the data is already kind of segregated and a very select group of patients that have a normal artery and none of this and none of that. So I don't see the reason in current day, okay? What are we trying to accomplish? So that's why we haven't been involved. The other thing, at least from Christian Etz, you know, he was at the critical issues meeting 2 years ago, and we had him talk about the technique, is that they started randomizing, and then in Germany, all of a sudden, everyone stopped randomizing. So now the trial can never be completed. So they are not doing a true randomization, and they're studying. The problem is, if you look at their primary endpoints, it's spinal cord ischemia and mortality in 1 month. Well, that's going to be a very difficult. It's all the secondary endpoints we care about, but the primary endpoint won't matter. You're not going to affect mortality. People don't die of spinal cord ischemia in 1 month, okay? So the number's not going to be different. So I don't think the trial is going to ever be positive anyway.
Yeah, right. I agree. Although, and also, when they publish that, if people start doing that, we're going to see a lot of accidents because it's not easy to do that.
No.
It's not easy, first of all. And then you're going to embolize, you can embolize the artery. So I think it's a very dumb study.
Yeah.
I don't know the way they're going to follow, but you know, as you said, stage, we also stage the cases. And also, we try, I'm not sure if you do the same, but we try to avoid leg ischemia. And what we do is when we do the second part of the procedure, let's say we are in the right side, we put the device in the right side, we let the left side untouched, we do all the branches, and if one branch is difficult, we leave there, we do the bifurcate, we finish the right leg, we close the femoral in the left leg, and then we go up to find these difficult vessels, celiac, SMA, or other artery. And then both legs are open. Yeah, at the end, when all the branches are done, we just go there and do the left leg. So in that way, from the beginning, we cut in the half the limb ischemia. And that changed a lot for us, the inflammatory response, the renal dysfunction. How you do in the same way?
Very, in some ways similar. So I always, you know, you need a 12 French sheath generally for the iliac contralateral limb. So I will go and I will get access with a 5 French sheath and an 8 French sheath and stop at 8 French, because an 8 French sheath's not going to inhibit leg blood flow. So I get my access, but I don't put the big sheath in like you do. I think that what we're going to have to look at, Marcelo, though, is the following. So Stefan and Tilo are now doing all their branches from below, not from above. Yeah. Well, that means it's going to be more leg ischemic time by doing that, because I'm like you. I put the T branch in.
I mentioned that to Stefan. When you go from below, first, it's not so easy as coming from above. And second, you're going to spend more time, and that means more leg ischemia in bilateral.
Well, yes and no. So there are ways to avoid the bilateral, right? But so if I had to do it, Marcelo, I would do the T-brace. I've done a few cases from retrograde. But you put the T branch, the infrarenal, the legs in, 8.5 Nagara sheath will work, but the best sheath is a 16 French. So you're going 16. So I would close the one groin, go to the other groin, do a 16 French, and let one leg go, and then go to the other one to 16, and then do it with the aptus sheath from above. It's not as hard as you think, but they're difficult vessels are difficult from above or from below. It doesn't matter where you come. And then you have to keep in mind what you taught us. So you cannot do the snare ride if you complete the infrarenal repair. You have no access to do snare ride. So you have to be sure that all your vessels are going to be easy to get into. So that's the one caveat where we don't do the infrarenal repair, is if I have a very difficult renal. It's normally a renal. The celiac and the SMA are generally never a problem. If one of the renals are difficult, then we don't do the infrarenal. We get the wire and the sheath in from above into that difficult target, and we put the stent in, the bridging stent, and stop. Then we complete the infrarenal, let the legs go, then we go back and deploy the one stent we have in, we then deploy it, and then the other three. That's the only thing I do differently than you in terms of preventing leg ischemia, because I may need that access from below.
Yeah, that's true. That's true. Very interesting. Leonardo Farber, I'll ask you about if you use sometimes this snare ride technique.
Yeah, so we've had to use it once or twice. You know, it's not common, but like anything, you have to occasionally use it to do stuff. So that's the thing. And if you close the infrarenal aorta, you have no access to it. So you have to be sure. Now, what's helped us, obviously, is, deflecting sheaths help us need it less than we used to. But all those sheaths are expensive, right? A deflectable sheath tip is not cheap. It's $600 or $800 in the U.S. for a sheath. So snare ride is much cheaper to use than doing a deflectable sheath. And if you're going to use the deflecting sheath, you need a long one. You generally need a 90 from the arm if you're going to do it, because you're already in a 1245 sheath or whatever from the arm, and to get into the renal, you need a 70 or a 90 sheath. So
I'll change a little bit the subject.
Okay.
I know you do also a lot of dissections. My first question is, so the patient came of type B dissection, and he had a good clinical initial result. After those studies published, you go and put a thoracic device, or you just treat, we still treat only complications at the beginning, or you go ahead and put your first piece in the thorax at the beginning?
No, so I'm like you, Marcelo. So we see the patient, okay? And if we admit him to the ICU, if the blood pressure's okay, we can control it, we wait. And I wait till 3-month time. If they have problems with immediate expansion and the aorta gets to be 4.5, 5 centimeters in the first week, we would consider doing it. If we see that the hypertension is not controlled and they have a dynamic obstruction, then we need to go do something, then we do that. So those are the ones that we would do earlier that become not truly symptomatic. Obviously, if they have malperfusion, you do it, but the hypertension sometimes is from a dynamic obstruction and they need too much fluid and they're on 5 medications for the blood pressure. That's the case. That's the only case that I will do and put it in, but that's to cure the hypertension, because we can't get them treated.
We still have 10 minutes, but I have 2 important questions for you. First, I have been talking about the lumen, the true lumen, the small true lumens, and I have been talking that's possible to do a branch device even in a small lumen. Now I'm doing even iliac bifurcated in very small lumen to preserve the hypogas in dissections. And so I'm a strong believer that to be free of the disease, you have to put the device in the true lumen or even the false, but exclude the false lumen.
Yeah, you know, Marcelo, Roy used to say that. Roy also used to say, when the device doesn't expand, it's because the false lumen pressure is high. Okay. Yeah. And I've seen now over the years 4 or 5 times. We have an infrarenal aneurysm we fix. Okay. And you put an infrarenal device in. The patient gets a type B or a type A dissection. And I've seen the infrarenal device collapse from the dissection. Okay. And so I know when the false lumen pressure is high, the devices will collapse. So when you see a device that hasn't completely opened in a dissection, you've stopped in the thoracic aorta, it's because there's high false lumen flow. And as soon as we extend through the viscerals and take out everything, the devices go to their nominal diameter.
Yeah.
And that's what I think. Look, you and I know you cannot sew to the septum. The septum cannot hold a stitch. So why would the septum prevent in of itself the device from expanding? No, it's from the pressure. Because if an aortic device expands the normal aortic neck to its nominal diameter, it should do the same thing to the septum.
Totally agree. But that so brings us to my second questions. It's why I do not agree, or it's my thinking in this stabilized technique. Even my son, I spoke to him. He's the leader of this study, but he has seen some infrarenal aneurysms of the stabilized technique. So I think if you do that, if you tell me, well, the guy was in a visceral ischemia, I opened the true lumen, ameliorates, but for the long term, in my view, you have now a very fragile aorta. So I'm not a big fan of this stabilized technique. Or your point?
So I don't know about stabilized yet, Marcelo. So from a physiologic standpoint, I think when you have 2 lumens, the mean pressure in the false lumen is high, okay? And I think that's why we always see the false lumens dilate. Now, if the stabilized technique reduces the mean pressure in the false lumen, and therefore makes it equal to the mean pressure in the true lumen, then we will see a reduction maybe in the number of aneurysm cases. I don't think they will all go away. No way. Because now 40 to 50% get an aneurysm.
Yeah.
Well, you know, so if that number is 5%, it's tolerable. If that number is 35% and it's not a big difference, then it's not a good technique. So I don't have enough data yet to know, is it rare that we see it, or is it almost as common? And it'll take 5 years to figure that out.
That's true, because in the first part of the study that it was published by Joe Lombardi, and he showed that about 25% of the patients in the 5 years, I'm not sure in 2 or 3 years, had an aneurysm, had aortic dilatation, because this fragile false lumen, when you rupture the membrane, now you have the whole thing fragile. So it's not a true aorta.
Marcelo, correct me. So I think in Joe Lombardi's, you're talking about the stable trial, yes?
Yeah.
So the stable trial in the U.S. did not do any rupturing of the septum. They just put the stent in, no rupture. Completely different than stabilize, where they're tearing the septum. And you know that Juan Prodi and I can't remember the other guy's name, have developed a septal cutter. They have now a cutter that you can cut the septum with endovascular scissors that they've developed now to see if that will make a difference. I don't know. You know, I haven't figured out why some people dilate, Marcelo, and some people don't. We don't have enough data on the pressures and how the connections are, but there's something there. We haven't figured it out. Maybe someday we'll figure it out.
Maybe one day, a fun day. But it's true that those we see the dissections, and when people leave, you see that at least 40 to 50%. I mean, those untreated, they develop aneurysms. So it's a progressive degenerative disease.
Yeah.
Yeah,
It's true.
good. So Mark, we still have some minutes here. And are you working in any new project right now?
So there's a couple new projects. One has to do with the spinal ischemia. So, you know, we have the NIRS, the infrared sensors we put on the thoracic aorta. And for me, as I said before, all the patients Gustavo and some other sites have problems putting drains in. You put a drain in and you have a complication. So people say we need to stop putting drains in. The problem is that when you have a patient with paraplegia, and maybe it's post-op, and maybe they're still anticoagulated a little bit, to put the drain in an emergency may increase their complication risk.
Yeah.
We know that rescue helps. We know that the sooner you get to lowering the blood pressure and so forth helps. So what we're using NIRS for is to help the nursing staff and everyone monitor the patient. And if I can see that the NIRS goes down sooner than the patient has symptoms, then I can say that patient right there is getting ready to have a problem, and I can start to intervene before, start to raise the blood pressure before, and so forth. That may be the mechanism we use to get the numbers down even further by an early warning system that you're getting ready to have a problem. So that's what I'm using the NIRS for. The other thing that we're working on and starting to do is the FORS, the fiber optic navigation. So Philips in the US and I think in Europe has a fiber optic technology you see the whole catheter. And so we can navigate now with the fiber optic catheter without radiation. And that's similar to the IOPS, which is electromagnetic, but the IOPS is just the tip.
That was developed by Eagleton?
By who?
Matt Eagleton from Boston.
No, so IOPS is Matt Eagleton. Really was originally Roy's, Greenberg's, and then Matt. But that's IOPS. FORS is Philips. It's completely different. Okay. Joost in the Netherlands is one of the big users of it. And now Tilo started to use FORS. But you see the entire catheter, which really helps.
Look, so we have 2 minutes. Next Friday, we have the Tropa de Elite guy, the guy who did this film, very interesting film about the crime in Rio, next Friday at 6 p.m. So,
Okay.
Mark, thank you very much. It was a great pleasure. This talk will be recorded and you can see later.
Perfect.
Even in YouTube or Instagram. And so in my name, Tamussino and Cook, we thank you so much to spend your precious time with us. So it's going to end abruptly, so don't be scared.
No problem.
Thank you,
Marcelo, look, thank you. Be safe. Tell Tatiana and the family to stay well, and we will see you or talk to you as soon as we can, okay?
Yes, I hope we see each other at the meeting. And
yes.
In his conversation for the first time in 2 weeks.
Okay.
Say hello
Alrighty.
to everyone. Take care. Good to see you.
All right, we'll do, Marcel.
Stay safe.
All right, bye-bye.
Bye-bye.
Bye.